So we're going to try to wrap around the point. Remember, we're going to embrace the point. So this low point, I'm going to start by adding flexion. Oh, keep your chin tucked. And then from flexion, I'm going to introduce side bending. And I'm bringing and as I do that, I'm rotating away, and I'm kind of side bending toward, and I'm flexing. And relax your neck. And how's that feel now?
Still tender.
As tender?
No.
So I'm going to add a little more side bending. How's that now?
Great.
So you're rotating away and side bending towards?
Yep. Common.
Because that shortens the muscle.
Yeah.
Could you add more flexion too, or that?
I could, but I was happy with the amount of flexion I had. You could add more flexion. They're all up for grabs, right? But what you're actually doing now, is it just shortening the muscle?
No.
We're actually compressing the joint, taking strain out of the joint. And could there be luminous distortions?
Yes.
All we know we're doing is we're resetting the brain-body conversation. If this tender point goes away, for whatever reason, we are recircuiting her.
Stephen, the angle at which you're side bending, would that be individual to the person? Going with breath and flow?
It would not only be individual to the person, but individual to the segment where you're at. The lower vertebrae require more side bending, more flexion, more rotation. The higher vertebrae, like C2, don't require any side bending and rotation. Side bending at all, or flexion. Pure rotation.
So C3, for example,
Almost pure, tiny bit of flexion, tiny bit of side bending, a lot of rotation. So, and that's why you use the book, to sort of get a reinforcement of that. So here's C3. C3, I would almost do a little bit of flexion and almost pure side rotation. I don't think any side bending. No, it doesn't like side bending. How's that?
Great.
Let's look at C5 on this side is also the same. So, lift up your head just a tiny little bit. No, lift up, please. So I'm locking my elbow, I'm leaning in with my body, I'm putting my elbow on the table, I'm going to introduce rotation away, a little bit of side bending toward, and how's that feeling?
Great. Way better.
I mean, I make it look a little easy, but I've been doing this for 25 years. But the principles are what's really important. You will find, once you find the tender point, if you really stay with it, you will find the position, remembering that the spine only does three things, right? It flexes, extends, it side bends, and it rotates. And if you keep thinking, if it's a front point, we flex, front flex, right? And we rotate away, side bend toward. And you just keep adding those different components, and you will find the place that makes the tender point disappear. You may need to get them to do, push your head back, please, and release. Yeah, good. That feels pretty good, huh?
knowing what we do of your practice, you don't do both sides usually, do you?
I treat the system where it lies.
Right.
I did both sides because she was tender on both sides.
Right.
And the tenderness in the other side didn't go away when I treated. So if there's a strong trauma,
You check.
yeah, if there's a strong trauma and a more, a normal level of loss of neural integrity is indicated by a single point. A higher level of loss of neural integrity and a greater level of derangement on the part of the brain-body conversation will have bilateral points, and I treat them both. I'm not treating the second point because I have some misplaced idea that symmetry is important, right? I'm treating it because the tender point is telling me that the data I gave from this side weren't sufficient to resolve that side. Does that make sense? Yeah. So don't feel guilty if you treat both sides. Don't think of me sort of whacking my finger. Oh, Land, So,
Go ahead, mark it,
so
man.
here's C1, and here's C2.
That's disappointing.
I can't see. Steve can actually see
Use your other hands to do what you're doing.
Hold on.
Can't you just rub
That's
it on her?
it. No. Pull that
You can write
top
on.
hand up.
It's
Right
really
down.
down that low? Okay, it's right under the ear. Okay.
What's down low?
C2.
C2.
So the lower
is
one
two.
is C2.
Yeah.
There's C2,
That's
and there's C1 right at the angle of the jaw. Now there's a C1 anterior point, which is interesting. It's a slight variation that's midway up the jaw and underneath in there. It's just called a C1 anterior. It's an atlas anterior point. So what's interesting is at C2, we have pure rotation, right? At the simple C2, C1 lateral, we have pure side bending. It's a lateral translation for these lateral points, and a slight rotation away, side bend toward, and really side bend toward into the anterior point on the jaw. We'll go into that in more detail when we do it.
Pure
You're
side
scrumping
bend.
up your face.
I'm concentrating with every ounce of
Okay,
brain I have.
but you're okay.
Yep, I am.
So C1's here,
Okay.
C2's there, C3 is there, C4 is there, C5 is there, C6 is right down there, C7 is mid-clavicular line, and C8 is there at sternomanubrial. I mean, so
Got a right on her.
yeah.
Go for it.
These are-
Great.
you need those
And you
grease
can
pens.
study. You can
So
take your
C1,
picture.
C2, C3, C4, C5, often a really wicked one.
Oh, that's a better,
C6 over there. C7 right mid-clavicular. Here's clavicle, right? So mid-clavicular line, right, anteriorly. C8.
In a soft part there.
No, it's right on the bone.
On the bone.
It's on the upper edge of the bone. We'll get to that. I think of this almost more as an upper extremity point. And then C8 is where we're talking.
Is it on the knob or it's not?
It's right on the knob. Here's the manubrium, right?
Okay.
Here's the joint.
Okay.
And it's right on the clavicle side of the joint, like
Okay.
right there. Not as bad as it was, but it's still talking to you.
way.
Yeah. Yeah.
Isn't that
He calls it
common
C8.
Go to C7? Okay.
Okay?
Thanks.
So it's on the clavicle side of the joint.
Yeah, it's on the clavical side. I find myself with people with shoulder injuries, with thoracic outlet injuries, that C8's a really important point. I find myself doing it a lot more than C7. There's a rib point we're going to be talking about soon. That's also along the mid-clavicular line. That's, here's our first rib. Here's our first rib. Here's the clavicle. Here's the first rib coming under the clavicle, around back and attaching at the spine. If we go to the angle of Louis, second rib is right there, and it comes right across. And at the mid-clavicular line, where the second rib is a nasty point relating to shoulder stuff and thoracic outlet stuff. Right?
That's the gate.
And it treats differently than the cervical spine. Right? We're actually going to rotate and side bend toward it. But that's another matter altogether. Yeah. Cool, huh? So the axis. So on the body of C2, and it's like this, and certain people have them. It's like a little golf ball that sits right on the body of the second
Is that what that is?
Yeah, it's in the muscle mass, and it's really swollen. The person's resting, and she's got a wicked one on the left. So film that over there. I mean, you can't really see much from that. You feel that.
So
Right
actually
there.
swollen and,
Oh.
Swollen, indurated, hardened. So feel that right. It's like a nodule, gently. It's on the bone, but it's really on the muscle.
Poor thing.
You okay there, Cheryl?
Yes.
Sure, it's going to pop any second now.
so
Already.
sometimes you can go, okay,
Keep
I'm gonna
poking
recognize
it.
we got a huge.
It's fixing the pop. Now, what is that?
You know,
Initially.
This is where the alien being pops out and runs away, right?
And what do you call that?
Is that C2 posterior?
C2 posterior.
Son of a gun, big bag.
Put your head straight back and you can feel it from the easiest from there.
Is that
Put your
a
hands.
calcification of some kind?
It's a neurogenic, right?
Neurogenic, okay.
Right? You've changed, since the nerves control everything, right? When
it's
you get
down,
nerve noise, right, it creates a localized tissue change. That is fibrosis, and if it goes on chronically, it'll probably turn to calcification. But it's at least fibrosis with an energetic pooling, right? You can feel the energy that's sluggishly kind of like pooling there. It's swollen. It's hot. It has all the classic signs of inflammation, which is swelling, redness, pain, heat.
And would that point be just painful?
It's a tender point.
I mean,
No,
just
no,
a
no.
touch. It wouldn't-
Big prominent C2, the spinous process, and here I am on this side, and that's a big knob, right there. I mean, it's classic, and it's real sore and real fibrotic and real swollen, and the treatment for it's really kind of unique. Is you're going to turn toward it, so you're going to turn to the same side and get her as far as she can go that way, and then I kind of sneak my hand just to support her head. I lock my elbow here. Now, what do we have to do when we go posterior? We have to go to the posterior, so we have to extend to some extent. But because of what C2 does uniquely, we're going to extend superimposed on pretty strong rotation. And no side bending at this level, right? We didn't side bend before. So watch what I'm doing to extend. I'm not dropping her off the table like I'm going to do otherwise, but I'm going to compress from the top and let go. I'm not doing anything sudden. I'm compressing from the top and I'm buckling the head.
And the left, are you holding that point on
I'm listening with the point. I'm listening to the point. It feels better. And immediately, slip a finger under there if you want to, and feel how it melts immediately. That fibrosis we were talking about.
So you're holding steady with the bottom hand.
I'm
and
just
pushing,
I'm providing a platform with the bottom
but
hand.
pushing with the top.
But it's really an excuse to provide a platform to put my finger at a listening point on the point.
Okay,
And then this is
hand
elbow in my belly,
and you're,
drop forward. I compress and it buckles her into extension.
Oh, I can now. Oh, there was a big release there. That's cool.
Yeah. Slip your fingers into the
Let me
list
go
if
see
you
where
want.
his hand is.
Right straight through.
Are you going just straight forward
Yeah,
here?
yeah. I'm going toward her left hip, her left knee, really.
And then the buckle is caused
gone, right?
Yeah.
by the
Compression.
other hand?
No,
Oh, the buckle's just caused
buckle's
by
caused
the
by my compression. I
straight
could
line.
take the hand away, and nothing happens.
Oh, okay, so it's
right?
straight line compression.
Yeah, straight line compression. She has to extend, right? It's extension in neutral.
Extension in neutral.
Extension and neutral. I'm gonna let that
Well,
percolate for a while.
It's actually called axial extension. So it's axial extension in neutral, right? Axial, her axis is extending. It's buckling and going backward. And even though she's in neutral, right? Yeah, sometimes in certain types of whiplash trauma, you find yourself doing axial. Everything okay? Did you guys get done with? No. Is that hard?
It's right back.